Hello, everyone, and thank you for joining us for Conversations and Cases, integrating recent progress in the treatment and management of relapsed refractory multiple myeloma. During this segment, we will be discussing a 75-year-old frail patient with early relapse, adequate organ function, and diabetes. I'm Dr. Saad Usmani, the Chief of the Myeloma Service at Memorial Sloan Kettering Cancer Center, and it's a privilege to be joined by two wonderful and esteemed colleagues, Doctors Jesus Berdeja and Paul Richardson. So, let's jump into the case because I would love to, get the take from my colleagues on managing, this frail older myeloma patient. We see these patients in our clinic, but there aren't a lot of clinical trial data to help us in guiding the management. We're typically extrapolating data. So this is someone, who was diagnosed about 4 years ago, and they started treatment, with RVD light, and this as we all know, the regimen that was published on by Betsy O'Donnell, a few years back. The patient got to a very good partial response, then was on lenalidomide maintenance for a year and a half, but then decided to come off of it because of dose adjustment requirements and such. They did have adequate organ function, but they did have type 2 diabetes, which was reasonably controlled. But their performance status is around 2. Now they're coming, they're progressing. The serum M protein is elevated. The patient has increased anemia and fatigue. Their performance status had improved to about an ECOG of 1, but it's now down back to 2. And we have to make certain, treatment decisions for this particular patient. So, I'm going to just jump into the discussion with my colleagues. So 3 drug regimens in frail patients. What do you all think? Do we feel that it is still a reasonable approach? If yes, why? Would you think that? And do you modify regimens? If not, why not? So I can start with my colleague Paul. Dr. Richardson, please go ahead.
No, I so agree with you, Saad. I think that the question here would be a 3-drug regimen to optimize synergy in the context of the different mechanisms of action. But to your point, dose modified to accommodate the fact that the patient is frail. So in this particular patient's case, obviously, one has the diabetes to bear in mind and the vasculopathy that may be associated with that. So perhaps reaching for a powerful proteasome inhibitor in the form of carfilzomib might be less attractive. Nonetheless, trying to leverage immunomodulatory drug would be important as well. So then one might think about pomalidomide in combination with perhaps a monoclonal antibody, for example, in an older patient, to me would be very attractive for this patient. And then I might actually reasonably keep the proteasome inhibitor, because that consideration is a little bit more tricky, in reserve. Although, of course, we were discussing in the previous segment the role of ixazomib, but that might be something that could be used at another time. In any event, certainly the use of a 3-drug regimen here would make sense to me, and something like pomalidomide, a CD38 antibody, and some steroid would make sense to me.
Thank you, Paul. Jesus, going to you. So this patient, decided to come off of lenalidomide about a year and a half or so ago. So Paul, that might also be, a potential, player here. So Jesus, what do you think? What would be, the options to consider? Because again, this is someone who has been off of treatment for a little while. So, we have a few, options to play with here. So what are your thoughts?
Yeah, no, I completely agree. I think in the frail patient, but first of all, 75-year-old, right? Fit frail makes a big difference. So we're definitely talking about a frail patient where the tolerance of the drug is of concern. And I think the aim of the treatment also is different. It may be mostly to keep things under control, not necessarily to induce the deepest remissions. So, but I do feel that even a frail patient can be managed with the triplet, and I do feel that they actually will get benefit from the 3-drug combinations, especially with the monoclonal antibodies. I do feel that the antibodies, so elotuzumab, daratumumab, cetuximab, add certain toxicities that are are very manageable. And give a significant benefit. So I think that's what I would concentrate with this patient. I think you could definitely go back to lenalidomide. It would depend on why the patient came off. How were they managed? A lot of times patients come off because they're having diarrhea, but they're not really appropriately managed necessarily, or interventions are not done to try and keep them on it, because I think ultimately, the oral combinations with the antibodies for this patient will probably be the most ideal. So absolutely, if they can go back to lenalidomide, that's a reasonable option. So I think Lendex is a fine option for this patient, for example. Pomalidomide was brought up, so perhaps maybe that has a better tolerance profile than lenalidomide sometimes, as long as you sort of protect them from infections from cytopenias they might receive. But at the end of the day, I think those are probably the most appropriate combinations. And I believe it was the French group at ASH, right, that published sort of the Dara-Len no-dex combination. So in an elderly patient, diabetic, if you wanted to spare them from dexamethasone, I think that would be a great doublet, for example.
No, certainly that was very impressive data in the newly diagnosed setting, and it's probably going to influence our practice. So I have a question for Paul, and maybe Jesus, you can comment on that as well, because we don't have a lot of clinical trial data in this older, frail patient population. With borderline performance status. So, my question is, what's your management approach? Would you start with, even if you start with a 3-drug regimen, which might be dose attenuated or tweaked, once patients plateau their response, do you back off of treatments or peel off certain agents? And what are your thoughts around that?
That's a super question, Saad. I think certainly in this setting, I would be embarking on a triplet approach. One antibody to mention that I particularly like in the elderly, because I think it's actually a very well-tolerated antibody, is elotuzumab. And so say, for example, obviously CD38 is a standard of care, so bearing that clearly in mind. But if there was any consideration to another antibody, elotuzumab might be something I would consider. And in that setting, perhaps the choice of IMiD, to your point, Jesus, you could, of course, use Len, but also POM in that same setting. Now, whichever one uses, and say for argument's sake, we use an IMiD plus the CD38, I would probably start with a relatively standard dosing approach. And to your point, Saad, then back off. Now, the question would then be, what do we, how is tolerance going? And certainly a monthly infusion of antibody, particularly the subcutaneous preparation Faspro, is so convenient. And at the same time, then dose reducing pomalidomide or lenalidomide, if that was the choice. I personally am more of a sort of POM user after Len exposure, simply because it's intuitively, I embrace that. And I think, Jesus, you made a very good point about tolerance, particularly GI. So I would look at Len, and then, I'd look at POM, I beg your pardon. And then I would probably look, to your point, Saad, at some form of dose reduction or dose attenuation to optimize tolerance. But frankly, in my experience, the pomalidomide plus CD38 platforms are very well tolerated. And I think you're absolutely right that POM, for example, at 4 milligrams might be somewhat of might engender some degree of cytopenia. So dose attenuation to 3 and 2 would be reasonable approaches, just for example.
Jesus, any additional comments there?
Yeah, no, I think I agree, but I actually have a little bit of a different take on these patients. I think my goal is to maintain them on treatment, and so I think I usually tend to go with a little bit sort of dose adjustment, to ensure that they can actually tolerate, and then maybe slowly, increase the dose if tolerated. Just because I feel that if you get that toxicity, this is the patient that's going to come off, and you're not going to be able to get them back on. So I think I think the main thing is to make sure you give doses that have been tested, published, just like RVD light, right? So we know that a 75-year-old perhaps is going to have a difficult time with 40 of dex. So that patient should be starting with 20 or less of dex already, right? The lenalidomide dose, if they go on lenalidomide or even pomalidomide, probably should be adjusted for the renal function once you get to that age. So as long as careful adjustments are made, I think it's good. But that's what I look for, is to just sort of kind of try and adjust to make sure they can stay on therapy.
I think that's an excellent point, Jesus. And just pivoting back, Saad, to the POM question. So therefore, starting at a lower dose of POM, especially if you're using, say, for example, daratumumab, you've got that weekly schedule for the first 2 months. You've got your coverage from your CD38. And if you start at 2 milligrams of POM, for example, you can then cautiously increase if they're tolerating it well. So I fully agree, Jesus. And we see that paradigm in other settings as well. I mean, for example, and one of the most striking oral agents in which it's so important to go low and go slow is selinexor. That's a drug where we've certainly found using it 40 milligrams once a week, interesting enough in combination with POM, particularly in 17p mutated disease, has not only been well tolerated, but really quite active. But your go low, go slow kind of approach, I like, has us fully agree.
Go low, go slow. I like that.
Yeah. Yeah, sounds very, rhythmic as well. So, so I have a question for both of you. So, before we got into this triplet versus doublet debate in relapsed as well as newly diagnosed space, and I know that's it's a water under the bridge, for the most part, but is there a role for doublets in some older patients? And what kind of considerations do you have, for a patient, like that? What would be the profile of someone you think about? Well, maybe let me just start with 2 drugs and maybe I can add a third.
After you, Jesus.
I think there is. I think frailty. We're here in the United States. We're not so good about assessing frailty like our European colleagues, right? But definitely, I think for the most part, we kind of use that eye test. But there's definitely frail patients, and there's really frail patients, and also it comes down to comorbidities. So patients that may have, for example, they may be frail, but don't have any issues with heart disease, for example. Versus somebody that already has cardiac issues, you might even consider, going into that carfilzomib space gently as a doublet, for example, versus in that one patient versus the other. But the other thing is just convenience, right? So some of these very frail patients can't make it to the clinics, so. If you could just give POM Dex initially to try and maybe get their disease better, maybe their performance status improves somewhat, and then they could come in and add the antibody. Those are the kind of scenarios where I would consider the doublet. But ultimately, with the goal of getting to the triplet, if the doublet's not sufficient. But if at all possible, it's still.
So what I'm hearing from from both of you is, there's a general consensus that, a monoclonal antibody, with a dose attenuated IMiD, maybe, pomalidomide preferred because of tolerability over lenalidomide may be an option for this particular patient, in terms of their profile. But, there are other triplet options that you may also consider. And again, this is where, I think the decision making becomes more of a team effort, where you're having that conversation with your patients and what they decide. Paul, I need your input on all oral options, potentially for this patient again, because we saw this with the other case, and we went through this during the pandemic with many of our patients as well.
Thank you, Saad. I completely agree. I think if an antibody, for whatever reason, was something to be kept in reserve or was difficult to operationalize for a patient, the use of ixazomib with POM in this setting might be a very reasonable and well-tolerated approach to consider. And I think that, obviously our data from the Alliance study showing really substantial PFS benefit to the triplet there, where at very low doses of dexamethasone in the frailer patients and just ixazomib and POM, we saw a median PFS of 21 months approximately for the triplet versus 7.5 months for the doublet, but with excellent tolerability. And so I think you're absolutely right, Saad. There are some good all-oral options for a frailer patient as well.
Now, this was wonderful. Thank you for comments from both of you. And thank you again for joining us for this segment on a 75-year-old frail patient with early relapsed multiple myeloma, having adequate organ function and diabetes. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credits, access supplemental slides, as well as other topic segments and case scenarios.